Thank you, Sherry. Good morning, welcome, and thank you all for coming to this meeting. ARS is the main intramural research arm of the USDA. We have about 2,000 scientists in the agency. We work on everything from crop production to animal health to human nutrition. The nutrition program is represented primarily by 6 centers around the country, 2 of which are congressionally mandated to work on childhood nutrition. There's one in Little Rock, Arkansas, and one in Houston, Texas. And we're fortunate enough to have Dr. Rob Waterland from the Children's Nutrition Research Center as one of our speakers this morning. Rob and other folks at both of the children's centers have been working on epigenetics for a number of years. And to me, epigenetics is relatively new. I've been in administration for 10 years and have not been actively conducting research in that time, although I'm supposed to spend a lot of my time keeping up with the latest research. So for me, epigenetics is one of those gee whiz fields that has a lot of fascinating numbers associated with it. So some of those numbers, which aren't going to be on slides, so you have to remember this, DNA in one cell is 2 meters long, but it folds up into a nucleus that's 6 microns across. That's just blows me away. Chromosomes have 10,000 loops that link promoters, enhancers with their genes. There are 4.9 billion contact points on your chromosomes. I mean, it's just phenomenal. One of the things that I learned from the most important scientific mentor in my career, that was David Krzyzewski from the Worcester Institute, was to give people the original credit who came up with concepts and ideas. And we spent probably as much time tracking down the first person who did something relevant to the papers we wrote as a team than actually doing the research. Because this was the time before the internet, so we'd actually have to walk across the street to the medical library to do that and go up in the stacks. So I had no idea who coined the term epigenetics, and that's credited to C.H. Waddington in 1942. And his concept was how genes might interact with their surroundings to produce a phenotype. Sounds very familiar. But the gee whiz aspect of that is in this month's issue of American Scientist, which is published by Sigma Xi, there's an article entitled The Forgotten Father of Epigenetics. And it's a relatively short piece that highlights the contributions to development in this area by Ernest E. Just. Dr. Just was an African-American embryologist on the faculty of Howard University here in Washington, D.C. He graduated from Dartmouth and received his PhD from the University of Chicago in 1916. Can you imagine what he had to do to achieve that 100 years ago? Thomas Hunt Morgan of Columbia University, who was a 1933 Nobel laureate, proposed that genes controlled all events of the cell throughout development. But Ernest Just proposed a theory of genetic restriction, that cytoplasmic factors interacted with nuclear elements to induce cell differentiation. And the truth appears to be somewhere in between these hypotheses. So I hope that the pendulum will not be at either one of the extremes at the end of this meeting, and you'll have taken home some important new lessons. So again, thanks for your attendance, and I hope you enjoy the next day and a half.
So thank you very much. I'm Sandy Hassink, and I'm the president of the American Academy of Pediatrics, and we represent 63,000 physicians throughout the United States and Canada. And I'm actually very grateful to be here today. Although you may not believe it, epigenetics has been on our strategic plan for the last 5 years at the Academy, along with poverty and early brain. And you might ask, what are all the clinicians having epigenetics on their strategic plan of the Academy of Pediatrics, which purpose is to drive clinical care. But our purpose is also to ensure optimal health for all children. And I think the presence of epigenetics on our strategic plan, along with poverty and early brain, represents a deep desire of clinicians to get to the underpinnings and the foundations of child health. And for that, I am very grateful to be here at this conference. So in our thinking about children at this point in time, I think we are folding our strategic plan and agenda under this framework, which may be very familiar to you. It's similar to the Harvard Center for the Developing Child, where nutrition is squarely in the center of foundational issue for children, for all children, for every child in the United States, both obesity, those suffering from food insecurity and hunger, and malnutrition, followed by stable and nurturing relationships, followed by a safe environment. And I think this is a social mandate that we have at this time as a country to ensure that our children have these foundations of health. You're very familiar with these CDC graphs, and I started my obesity practice in 1988 when obesity was not on people's radar screen, and we watched this sort of move through our adult community. And I think every time I see slides with this amount of geographical variation on them, I think two things. One is, what in the world is happening in these particular environments, and how we as a country are still dealing with these massive disparities in health across the country. And these slides can be reproduced almost on every health disparity we have. We also saw, and at the beginning of this obesity epidemic, and I'm looking at Matt, at the beginning when we saw the adults affected, we kind of thought maybe children would be spared, maybe somehow childhood would be protective in some way from from obesity and the sequelae of obesity, but children are not spared, they're not protected, they're suffering from obesity in high numbers at very early ages and with very dramatic impact on their health. So now we've got a cohort of children, 17% who have obesity, 30% overweight and obesity, who look in many ways like middle-aged adults in terms of the profile of the health they have. They have shortened telomeres, they have all the adult diseases. We didn't go into pediatrics to do these diseases. You know, we weren't expecting this as pediatricians. And so this is what we are seeing and dealing with every day as clinicians. Thanks to Leanne, and you'll recognize this socioecological model, which we adapted, Leanne, we are dealing in a milieu now that is a very complex socioecological milieu. And we have very blunt instruments as clinicians to deal with obesity. We have food, and we have exercise, and we have the behaviors that mediate that and the environments that mediate that. And so this is a very complex environment that we are working in with sort of very blunt instruments. These are the factors that are affecting infants, and these are the factors affecting toddlers. We're very focused on this young age group because we feel that once a child develops obesity, you have an adolescent with morbid obesity, there's no going back on that, even with extraordinary effort. We know that children are vulnerable, and we know mothers are vulnerable. So what happens to the mother happens to the fetus, happens to the infant. We know this, but we as clinicians have been able to go no further than this knowledge. We don't have ways of intervening yet in a practical sense, and so this is why this is so important for us. And we know that the environmental influences are profound on physiology and behavior of energy intake and utilization and energy expenditure, and we know that we have this longitudinal effect and multi-generational effect. Longitudinal effect on the child, what happens in that fetus or that infant has longitudinal effects, and we have multi-generational effects. And we don't know exactly where to break this cycle or how to break this cycle. Again, this is something that will be familiar to clinicians. This is a growth chart, and from clinic, I don't think my pointer's working, but you'll see that the line for weight is in the height curve. Matt's looking, I'm looking at you, Matt, because I know you're nodding, you've seen this many times. So this is often what the clinician is confronted with. And this is, I would say to you, is a biologically kind of implausible curve. This is a curve that has escaped control mechanisms. If you saw this in a Petri dish, you would say, well, you know, this is not logical. Something is accelerating here. Something's becoming exponential here that shouldn't be. And this is what we're often contending with. We feel as pediatricians, we are in a position to operationalize whatever we can understand about early obesity. Children have maximal access to pediatric visits in these early ages. This is an important period where we're establishing lifelong nutrition and activity behaviors. We have the intersection of this with parenting, and we know that parents don't have often the skills to do this, and we're frequently teaching parenting skills in clinic to get action on these health behaviors. But we feel like we have an opportunity here, and we have an opportunity to do cumulative intervention across the lifespan. So these are just what it looks like as a pediatrician. You know, we have 31 at least well-child opportunities, but 20 of them are concentrated in the early years of a child's life. So we, as clinicians, feel we have a window of opportunity here. Because of our interest in obesity, which has been on our strategic plan for at least the last decade, we have evolved that into an Institute for Healthy Weight at the American Academy of Pediatrics, specifically to serve as a translational engine. And so this is, again, particularly why I'm so pleased to be here, because we are ready, willing, I don't know if we're able, but we're ready and willing to try to translate some of these, the research findings into action. And you can see our goals are treatment, prevention, and treatment, partnering with families, and a stake in the community where that's needed to do this. And our two primary strategic objectives here are early obesity prevention and treatment. And that's on our current strategic plan. And you can see those that we are partnering with around these two strategic objectives. And the reason the partners are wide and some of the partnerships are deep is it reflects the niche, the complexity of the problem we're trying to solve here. So I'm particularly pleased to be partnering in this venue with our research colleagues, because I think you will inform all these other partnerships by what's happening here. So this work is important because we need to understand what's happening in a very deep, profound way. We have potential periods of intervention. This work is important because we will use it to guide our early childhood obesity prevention and intervention efforts. We will use it to educate our clinicians and providers and teams, and we will use it in our advocacy efforts and our help for families. So this is profoundly important to us, and I am so grateful to be here today. So thank you very much.
Good morning. Thank you so much for being here, and welcome. I'm Jamie Bussel with the Robert Wood Johnson Foundation, and epigenetics is not on our strategic plan. But that being said, early childhood absolutely is, and I will have to admit that when Anne approached me over the summer and said, would RWJ be interested, I had to Google what epigenetics was, so let's just put it all out there. What I thought I would do this morning really quickly is provide some bit of background on sort of the history of the foundation's work in childhood obesity, talk a bit about our work going forward over the next decade, and really why a meeting like this was of great interest for us. So it's hard for me to believe that it was actually over 8 years ago that the Robert Wood Johnson Foundation announced its $500 million commitment to preventing childhood obesity. And I believe that this was actually the largest prospective commitment that the foundation ever made in a single health issue. And at that time, the foundation set a pretty audacious goal of decreasing the prevalence of childhood obesity by 2015. And so I'll say I think the evidence of progress is strong and absolutely exciting. We believe we're turning the corner on childhood obesity and that we are on the right track. But we haven't come far enough. And so despite all the gains that we've made and reported on so well, the fact remains that progress has been shared unequally. White children and children in higher income areas are seeing a greater decrease in obesity rates than others. And today, more than 25 million children still remain at risk for cardiovascular disease, type 2 diabetes. And unless something is done to address this, we are at risk of raising the first generation of children that will live sicker and die younger than their parents. And so I know that those statistics are quoted often, and I'm in a room of scientists and researchers that know them better than I, but I still find them pretty staggering. Our nation's level of obesity and the dire health consequences that it leads to is not and should never be acceptable. We must do whatever we can to ensure that all children in all communities have the opportunity to grow up at a healthy weight. And everyone has a role to play. in realizing that vision. Parents, children, community leaders, industry leaders, policymakers, the academic and scientific community that's represented here this morning, advocates, everyone. You may have heard a small announcement that we made earlier this month that was delivered by our president, Dr. Risa Lavisa-More, that we're not relaxing our commitment in this area, not even for an inch. And we'll commit an additional $500 million over the next decade to continue our work, to expand our work to ensure that all children in our country can grow up at a healthy weight. And this will bring our total investment at well over $1 billion. So I just want to highlight an important theme that I think will really be driving over the next 10 years, not just in terms of building the evidence base, but also in terms of building demand and supporting action and advocacy in this arena. And it's a theme I think that's echoed well in this conference. To achieve our new goal, we will all work with an intensified focus on reducing disparities, because we know that in 2025, we will not be able to declare success if some kids and some communities have been left out. So the Foundation's new strategic objective around childhood obesity aims for all children in America to be at a healthy weight, no matter who they are or where they live. The evidence tells us that when children enter school at a healthy weight, they're more likely to maintain that healthy weight through adolescence and well into adulthood. So we need to get kids going down the right path from the very, very start. And that's what's so exciting for me today about this meeting. We know obesity has its origins in early life, and that the first 1,000 days from conception to a child's second birthday is a crucial period for development and prevention of obesity and its consequences in children and families. So I hope, as a consequence of this meeting, that we build a stronger understanding of the relationships between obesity and the most critical periods of development, and we can translate that science into really good programming and policy with great potential to support kids in growing up healthy. We need to start early. We at RWJ are not exactly sure how to do that or the best places to start. And so this meeting and a lot of the exploratory work that we're actively engaged in are going to help us get it right and ensure that we can support strategic science going forward and really good programming and really good policy. So just to provide some really quick highlights of how we're organizing our new work going into this next decade, we plan to concentrate on 5 key strategies, what we're referring to internally as our 5 big bets that'll help all children grow up at a healthy weight. Big bets that will contribute to building a strong, inclusive culture of health. So the first of those big bets, and the one that I think is most relevant to the next day and a half's work, is on ensuring that all children can enter kindergarten at a healthy weight. The evidence clearly tells us, again, that when kids enter school at a healthy weight, they're more likely to maintain that healthy weight. So we need to get them going down the right path as early as possible. And that means working with parents before the babies are born and that those babies grow into young children. It means understanding the most important research questions and being able to invest in finding answers and supporting strategic science that'll be translated into good practice and good policy. We must do more to link families with the support and resources that they need beyond the clinic walls to help their kids achieve and maintain a healthy weight. And we need to better understand the science and the most salient strategies that support changes at the individual, family, and systems level, and which begin in the earliest stages of life. Our second big bet is making a healthy school environment the norm and not the exception. I'd say that that's been a place that we've been in for a long time and have really focused on school-age children, and so we're definitely moving back and really focusing on early childhood, but absolutely schools still remain a significant setting for us going forward. Third is making physical activity a part of the everyday experience for every child. Getting up and moving around shouldn't be something that's confined to one period at school. It has to be fun. It has to be part of sort of the utilitarian, purposeful part of everyday life. The fourth big bet is the elimination of sugar-sweetened beverages, the total elimination of consumption of sugar-sweetened beverages for kids 0 to 5. There's no reason for it. We need to build healthy habits from day one and really avoid that uphill battle of undoing bad habits later, which we know is a whole heck of a lot harder. And then last but not least, the fifth big bad is also a space that I think we've been in for quite some time, and that's making healthy foods affordable, available, and a desired choice in all neighborhoods. So we remain ever committed to eliminating food deserts. Every parent should be able to find healthy, delicious, affordable food in their communities every day, so that they can prepare nutritious meals and maybe even with their children. So I think if we can do all these things, we can achieve a society in which all children enjoy a healthy weight in childhood and well throughout their adulthood. And we'll make significant strides in building a culture of health for generations to come. So I thank you all for being here. I'm really excited. I got a lot to learn, and I hope I get to say hello and meet everyone in this room. So thank you, and thanks, Ann, to you and Sherry and the planning committee.